Hello, everyone. My name is Gurjot Basra, and I'm the Manager of Patient Programs, Research and Advocacy at Lymphoma Canada. I'm very pleased to welcome you all to this breakout session on Waldenstroms macroglobulinemia, also known as WM. So just before we start, I do want to go through a few housekeeping items. This Zoom software does not allow you to access chat features or turn on your microphone. So if you have a question, this session will be followed by a live Q&A session. So please keep your questions in mind and be sure to attend the indolent non-Hodgkin lymphomas Q&A afterwards. So to introduce our speaker today, we have here joining us Dr. Neil Berinstein, who is a hematologist or oncologist at the Odette Cancer Center at Sunnybrook Hospital in Toronto, Ontario, and a professor of medicine at the University of Toronto. His clinical practice focuses on lymphomas and plasma cell disorders. His research focuses on novel approaches to treat hematologic malignancy, including combination immunotherapy and new targeted agents. He has led several multi-center translational clinical trials looking at novel therapeutics and identification of novel biomarkers. So thank you, Dr. Neil Berinstein, for joining us today, and you can get started as soon as you're ready.
Okay, that sounds great. Thank you for that introduction. I'm very pleased to be here today to talk a little bit about Waldenstrom's macroglobulinemia, a disease that I've uh, become quite familiar with, and I am doing some research in this disease. So I've been asked to talk about the disease in general and some of the new treatments that we have for Waldenstrom's macroglobulinemia, both in the front line and relapse setting, but also to talk a little bit about the clinical trial that we have conducted over the last 4 or 5 years across Canada with 10 sites across Canada that we're very proud of. To have gotten the buy-in and the participation all across Canada for this trial. So that's what the agenda is going to be like. I'd like to thank Lymphoma Canada for inviting me, and my uh, oops, this is not working. Doing wrong here. My disclosures are shown here. The trial I'm going to be talking about, we received research support from AstraZeneca, and I've been participating over the years in a number of different advisory boards um, in the field of lymphoma and myeloma. So we'll start off with a brief introduction about Waldenstrom's. It's an indolent, uncommon, non-Hodgkin's B-cell lymphoma. It has one of the highest associations with a genetic mutation of any of the cancers that we know of, and that is the mutation of MYD88, which occurs in up to 95% of patients with Waldenstrom's macroglobulinemia. So it's a very strong association. And the other feature about Waldenstrom's that is very interesting is that the cells secrete an IgM paraprotein. It's actually an antibody molecule into the serum, and the amount of IgM paraprotein is directly proportional to the bulk of lymphoma that the patient has. So the IgM is a surrogate for monitoring the disease and response to treatment and evidence of progression. It's a very interesting disease from many perspectives, and as well as having the types of features that one associates with lymphoma, which is enlargement of lymph nodes or liver and spleen. The IgM paraprotein itself can cause many unique clinical syndromes, such as hyperviscosity, cryoglobulinemia, where large amounts of specific IgM proteins can cause vasculitis or hemolytic anemia, and also neuropathy. These are features that are unique to this type of lymphoma. Over the years, there have been many different treatments that have been employed for this disease. And for the most part, none of these are felt to be curative. They're all pretty good, but they basically cannot cure the disease, and some are more active than others. And the type of treatment one gets might depend upon the geographic location where you're diagnosed with this type of lymphoma, and different parts of the world use different first-line treatments. And we're going to talk about that shortly. And as in all diseases and all cancers, clinical trials to develop new treatments and better treatments are important, and that's why we're going to talk a little bit about the BROM trial. So there are several different first-line treatment options, as I mentioned already, that can generate relatively durable responses in most patients. But even though almost all patients respond, the depth of response is not that great. It's unusual to have complete responses, and very good partial responses are also pretty uncommon. And this sets it apart from, let's say, the aggressive lymphomas, where we can cure aggressive lymphomas, such as diffuse large B-cell lymphoma, but the CR rate there is 70%. The CR rate in Waldenstroms is much lower. Um, and one of the treatments that we use that has become very important, particularly, let's say, for recurrent Waldenstroms BTKI therapy, is given continuously. It's not fixed duration and can be associated with ongoing cumulative toxicities. So there's a lot. The reason I mention these things is there's room for improvement in how we manage this disease. Now, I said that for the most part, people who have this disease do very well, and the median survival can be 15 to 20 years for many patients. But there are some poor prognostic subgroups where the expected life expectancy is much lower. And so I'm going to talk about these because these are not necessarily all that uncommon, and it's important to when we look at new treatments, it's important to see how these new treatments do in these patients who fall into these different uh, prognostic subgroups. So I'm going to be talking about stage. So I said high stages is associated with poor or prognosis, molecular subsets. Some of these are associated with poor outcomes, and then the depth of response. How deep is the initial response? Do we achieve CRs or PRs or VGPRs, and how that influences what the actual outcome for the patient is? So this is just something which looks at stage. This is some data which looked at a number of patients that were treated, and they basically used the common international staging system for Waldenstrom's macroglobulinemia, which is based upon age, beta 2 microglobulin, LDH, and serum albumin. And they broke people into their basically stages. And what you can see is that if you have the higher or very high stages with three risk factors or four to five risk factors, your prognosis is not that great. And in fact, if you look at the actual 5 year survival that's expected in these patients, if you have a very high staging system at initial diagnosis, your 5 year expected life expectancy is only 36%. Only 36% of patients will live 5 years, and 10 years is 9%. So even though the bulk of patients with Waldenström's do much better, clearly we're identifying a subset of patients that don't do as well. Now, I'm going to show you the same type of data with molecular variants. Now, there are there's actually three important molecular variants. One is MYD88. So I said 95% of patients have MYD88 mutation, and that's fine. And if you get a BTKI therapy, you actually do better if you have this MYD88 mutation. And if you don't have an MY, if you're one of the 5 or 10% of patients who don't have an MYD88 mutation, you won't respond as well because these mutations are driving to some extent the lymphoma or the Waldenstroms, and BTKI therapy is designed to overcome that drive. And if you don't, if your lymphoma is not driven by it, then it makes sense that you wouldn't do quite as well. Now, here's another bit of data for patients with CXCR4. Now, we mentioned that MYD88 is mutated in 95% of patients. Well, CXCR4 can be mutated in up to 30% of patients. And this is another pathway that can drive the lymphoma, the Waldenstroms. And if you have this mutation, you're not going to respond as well to a therapy like a BTKI therapy that's aimed at MYD88 mutation, or the drive that's caused by MYD88, and that's shown here. These patients don't do as well with BTKI-based therapy if they have this CXCR4 mutation, and this has been shown in a very large subset of patients. This is just a summary of this data, and this is looking at the statistics behind it. So the first thing to take away from this is, yes, if you have the staging. So this is the staging system for Waldenstroms, the International Prognostic Staging System for Waldenstroms. In a multivariate analysis, as I showed you earlier, the stage predicts outcome, and that's on the whole cohort or patients who uh, basically get a fixed duration chemoimmunotherapy. Not so much, it doesn't seem to be as influential on the patients who are getting BTKI-based therapy. Now, if you do get BTKI-based therapy, though, however, you will do better, and your risk of having some sort of event is lower if you have MYD88 mutation. But if you have the CXCR4 mutation, you're more likely to have progression if you get BTKI-based therapy. So this is summarizing what I showed you before. These are a number of different studies which again point out one additional feature about CXCR4 mutation. This is the second mutation I was talking about that can occur in 30% of patients with Waldenstroms. And that is that it takes longer to have a response um, if you have CXCR4 um, um, mutations. Um, and if you look over here, the VGPR rate is lower, and the progression-free survival is shorter in patients who have CXCR4 mutations. So this is interesting data, and again showing the importance of CXCR4 mutations. Um, Again, P53 is an anti-oncogene that can be mutated in many different cancers. If it's mutated in Waldenstrom's, again, the time to progression is much shorter. The time to treatment start is much shorter. You need treatment much more quickly. You will progress much more quickly, and your survival will be poor. So this is giving us ongoing prognostic information. And this was confirmed in the Aspen trial, which was a trial which randomized patients to either ibrutinib or zanubrutinib. And as I say, most patients do have MYD88 mutation, but if you in addition had a P53 mutation, your VGPR rate was 13% as opposed to 30%. And actually, it seemed to be a little better if you had treatment with zanubrutinib. So it turns out that zanubrutinib may be a little bit better treatment against patients who have P53 mutations, but P53 by itself is a poor prognostic factor. And the last bit of data I want to show you um, is important because it shows that the depth of response from your initial first line therapy can be predictive of how you eventually will do. And this is data from four different trials. It was basically the data was put together, was merged, and a total of 440 patients were assessed. And they were basically, the response was based upon the International Prognostic Group response criteria. And you can see, first of all, the point that I made initially, which is that the CR and VGPR response rate is only about less than 20% at any of these time points. And if you look at the major response, which includes PR, it's closer to 70%. And we're looking at the outcome of the 70% of patients who had a major response versus those that didn't have a major response. So if you had a major response, your progression-free survival is superior over the years, and this is going out to 10 years. And your time to your next treatment is also longer. And your survival is also better. And events relating to disease-specific events are less frequent if you have um, a major response to your frontline therapy. So this is telling us something about therapies. Now, this may be a feature of both the biology, but also the therapy, that we really want to look at therapies that can produce deeper responses because, in general, patients who have deeper responses do better. So, summary of everything that I just showed you with a number of different treatments, which are just sort of listed here from BTKIs, bendamustine, Rituxan, bortezomib, which is used in a number of different regimens. And the bottom line here is that the the overall response rate is pretty high. I mean, most patients who get first-line treatment for Waldenstroms have a response, but deep responses, you look at all of these here, are actually quite low. And if you look at progression-free survivals, the progression-free survivals are pretty good. Patients are, on average, having a median progression-free survival about 5 years. This is with bendamustine and Rituxan, which is the treatment we use in most places in Canada. And then there's bortezomib-based treatment where there also is a very good progression-free survival to first-line therapy. We don't really use bortezomib-based therapies because one of the side effects of bortezomib is it can cause neuropathy, and many patients, about 25%, in fact, of patients with Waldenstrom's will have significant neuropathy at the time they have therapy. So it doesn't make sense to incorporate a drug that can make that toxicity worse or that symptom worse. So, just to put the treatment that many of you, if you have Waldenstroms or have had treatment for Waldenstroms, will have received, it was probably in Canada, it's bendamustine Rituxan, and this is data from the STILL trial, and this is comparing bendamustine Rituxan to CHOP Rituxan, and this is the data that we use to justify or to warrant the bendamustine Rituxan treatment with a median progression-free survival of about 69 months. This type of data has been duplicated in a number of different trials. And just coming back to this theme of CR and VGPR, what is the CR and VGPR bendamustine Rituxan? Well, it varies from study to study. The CR rate is relatively low. 40 patients out of 289, if you add all of these trials together, had a CR. Higher number had a VGPR, which is almost a CR, and the overall combined CR and VGPR rate is 46%. The difference between a VGPR and CR is that there's a test called immunofixation electrophoresis, which is a very sensitive test, which is still positive um, in one's blood in patients who have a VGPR rather than a CR. In a CR, it becomes negative, which just shows a higher level of cell kill. So about 46% of patients treated with bendamustine and rituximab might have what we consider a deep response, CR and VGPR. You have to remember this number because the trial, which I'm going to talk to you about in a minute, the BROM trial, was designed to show that if it's if the result is positive, the actual response rate will be higher than the historical result of 46% seen with bendamustine and rituximab. And well, what is the CR and VGPR rate with BTK inhibitors? Well, again, with BTK inhibitors, and this is looking at the three different BTK inhibitors, ibrutinib, zanidatamab, and acalabrutinib, the OR, the objective response rate, is very high. Almost everyone responds to a BTK inhibitor when they get it as first-line therapy. And the VGPR rate and CR rate again is quite low. We're looking at this is it. This is the combined CR and VGPR rate, and all of the with these three different BTK inhibitors, 30%, 28%, and actually very low rate here for it's closer to 7%, or actually it's shown as 0% here. Um, and these are the individual trials. Again, high response rates. Time to response is reasonable, but the CR and VGPR rate is closer to 30%. So this is not higher than bendamustine and rituximab. But you might predict that if you were to combine this type of agent, a BTK inhibitor, with bendamustine and rituxan, you might see an additive or even synergistic effect. Um, or an enhanced effect on CR and VGPR. And that's exactly what we did. And I'm going to show you the results of that in a moment. If you look at the National Comprehensive Cancer Network, which is an American-based network that puts together treatment recommendations for different types of cancers, their conclusion is that preferred regimens are bendamustine rituximab. I told you about the bortezomib data, and then there's rituximab with a different alkylating agent, cyclophosphamide, but we believe the results are better with bendamustine. And then you have a number of other therapies that could be considered, other recommended therapies, and these include the BTKI inhibitors. At the time when this was published, the ones that were approved were ibrutinib, Um, and then, of course, the bortezomib combinations. So in Canada, most places in Canada, first line therapy will be bendamustine and rituximab. Second line therapy, once one relapses, can rarely be bendamustine and rituximab if you've had a really outstanding response and you have good bone marrow function. Rarely, bendamustine and rituximab could be repeated. Most of the time, one will initiate a BTK inhibitor therapy, which is continuous therapy, and probably now the agent that's preferred is zanubrutinib. And then what happens if you relapse after that? Well, we're going to talk about that at the end of the presentation. There are new drugs in development, and we'll talk about that. Another entity which occurs sometimes is transformation, where your uh, indolent Waldenstroms macroglobulinemia lymphoma acquires additional mutations, such as perhaps c-MYC or other mutations that make it more aggressive. And at this point, one needs treatment for an aggressive lymphoma, which is CHOP and Rituxan, and maybe stem cell transplant, and then CAR T cells is experimental, and it can be something that can be used at some point for patients with a transformed lymphoma. So, and one last slide before I go into the trial that I'm going to show you about, which is what what are the new approaches for treatment naive Waldenstroms macroglobulinemia? What are different research groups across the world doing to try to um, improve upon our results? So there is the Zebra trial, and the Zebra trial is a trial that's a relatively new trial. They've just started recruiting or patients in the last year. It's out of the Massachusetts General Hospital, and it's bendamustine rituxan and the addition of zanubrutinib, which is, as I said, a pretty good BTKI inhibitor for patients with Waldenstrom's macroglobulinemia. The trial that I'm going to tell you about, which we actually started about 5 years ago, so it's was, I guess, ahead of its time, at least compared to the Zebra trial, combined bendamustine rituxan and acalabrutinib. We didn't use zanubrutinib. Um, and again, for first line Waldenstrom's macroglobulinemia. Now, there are some other trials that are looking at novel agents, venetoclax, which is a BCL2 antisense with rituximab, or with ibrutinib, a BTK inhibitor. And there's one that combines venetoclax with a non-covalent BTK inhibitor and rituximab. And then there's ixazomib, which is a less neurotoxic version of bortezomib, and it's combined with rituximab. So these are the treatments that are underway. Some of them are still active. Some of them are now in the follow-up stage where data will probably be made available soon. I hope to see some of these at the upcoming American Society of Hematology meeting. So, as I mentioned, the BROM trial, which is bendamustine, rituximab, and acalabrutinib, and Waldenstrom's macroglobulinemia, is a trial which aimed to combine bendamustine rituxan, which is basically standard of care, with a BTK and high inhibitor. And there are a few novel things that were done here. Well, one is that um, uh, this combination, which at the point when we did this was a novel combination, had or when we initiated this trial had not been done previously. Now there are these other trials, which some of them are sort of duplicating this type of idea. But in addition, we made the BTKI inhibitor a fixed duration. So as opposed to continuous therapy, which goes on until patients progress, which can be 5 or 6 years or whatever, before they start having progression from their BTKI inhibitor, we said, okay, we're just going to give it for 12 months because we're already combining it with a very strong treatment, bendamustine rituximab. We'll get a very strong initial response, and that should be allow us to stop this BTKI early. And by stopping the BTKI after a year, we avoid some of the long-term, what we call toxicities of special interest. The BTKI inhibitors are associated with things like arrhythmias, which means atrial fibrillation, an increased risk of bleeding, and hypertension. And hypertension is quite an important problem, and up to 50%, 40% of patients will have worsening hypertension during that 4, 5, 6 year period of time that they're on a BTK high inhibitor. And this is worse with ibrutinib and not as bad with, let's say, acalabrutinib or even zanubrutinib. Excuse me. So the BROM trial was a Canadian trial. It was sponsored by, or was funded by AstraZeneca, and the sponsor was the Sunnybrook Research Institute, and I was the principal investigator. We had co-principal investigators at each of these sites, spanning from Vancouver to Halifax. Um, and the objective was to document the best combined complete response and very good partial response rate of first-line treatment with bendamustine rituximab and acalabrutinib in patients who have never received any previous treatment for Waldenstroms. We used response criteria from the sixth international workshop on WM, which are pretty standard, and we documented responses at multiple different time points using the IgM, imaging if there were abnormal lymph nodes, monoclonal protein by immunofixation, and bone marrow involvement. And there were a number of secondary objectives, and some of these were sort of translational and research, such as MRD. And I'm going to show you some of the MRD data, but the others are pretty standard, such as progression-free survival and duration of response and time to next treatment. And so we enrolled 63 patients. We needed 59 patients. And with 59 patients, if we had 34 CR or VGPRs, the lower level of the response rate confidence interval would be greater than that 46%, which I showed you as a historical CR and VGPR rate for bendamustine and Rituxan. So that's what we wanted to see. In fact, we did meet that endpoint, and the result is considered a positive study. Now, the design is shown here. Um, Patients received 6 months. This is standard of care, bendamustine and Rituxan every month, and 1 year of continuous acalabrutinib, 365 days. They had disease assessments prior to any treatment and then every 6 months after that. And we did some translational studies, including MRD and blood and bone marrow at each of these time points. This is something that's never been done before in Waldenstroms, so we think these results are important, will become even more important as we get some of these results from these later time points. We don't have them yet because the study is still ongoing. We've completed accrual, but we haven't completed follow-up. And patients had to be symptomatic to get on the trial, and they had to have some sort of measurable disease, either an IgM paraprotein or lymphadenopathy, and they had to agree to the different study procedures. So we basically did a data cutoff in December 2024. That seems like a long time away, but by the time you put all the data together, it takes a while. And we did present this at two different meetings, one being the International Workshop on Myeloma and also the International uh, Conference on Malignant Lymphoma, which was at Lugano, both last spring and summer. And and now this data is out for publication, for consideration of publication. And we assessed 78 patients. 59 patients made it into the trial. Actually, 63 were enrolled. Four discontinued early for various different reasons and didn't make it to the complete assessment, first complete response assessment. Nevertheless, they are included in our intent to treat. And just to show you that, I mean, this study is ongoing, and at this point, all patients have completed monotherapy, but there are many patients who are at various stages of either 18 months, 24 months, 36 months of follow-up. And I'm not going to go through all this data. This is data that will eventually, I mean, that are available. They're actually online because they've been presented at these meetings. Just a few interesting things. One is that median age was 69. And these are the different molecular subgroups. And it really wasn't, the age was not statistically significantly different in the different molecular subgroups. There were more men in the trial for some reason. And the median IgM at the time of starting or entry into the trial was 37, so that's quite high considering that number should be zero. Well, it should be under 2.5. And the bone marrow involvement, 61% had greater or had less than 60% bone marrow involvement, and 31% had greater than 60% involvement. And then we talked about the high international workshop and Waldenstroms staging system. Actually, 50% of patients had a high risk score. So these are patients who basically, according to the data I showed you, would not be expected to have as the 15-year median survival that I discussed earlier. So this is the interesting data. It shows a lot of data here. It might be, if you're not familiar with Sankey plots, this is uh, you might find this a nice way of showing data. This is the response rate at cycle 7. So you can see there was a CR rate of 3.4%. The VGPR was 60%. So the combined CR and VGPR rate was 62% at this time point. And then we look at time point 12, it's the 12 months, it's 61%. And then at time point 18 months, it's the CR and VGPR rate is 60%. And this shows you that some patients who had a partial response um, actually developed a VGPR response by time point uh, 12. And there were no patients who actually developed worsening um, responses at any of these time points. There's a number of patients who, because not all these patients had reached the 18-month time point, who are still pending. So you can get a feeling for what's happening to these patients who have CRs or CR or VGPRs. And for the most part, the conclusion here is that they're staying stable. They're not these are durable CR and VGPRs. Now, we looked at the CR and VGPR rate in a different molecular subgroup. This is the CXCR4 mutated, which I showed you as a poor prognostic group. And this is the wild type MYD, which is also another poor prognostic factors. And these are the CR and VGPR rates at the cycle 7. And they're pretty comparable. This is a bit lower than you see in the overall the MID 88 mutated CXCR4 wild type group, but it's not significantly so. And then these values are also stable with time. The CR and VGPR rates don't really significantly change with time. So they're durable responses. I'm going to go over this results very quickly, but these are we saw a lot of patients who became MRD. So this is looking at a very sensitive level of looking for evidence of lymphoma cells in the peripheral blood. And when we did that, almost 80%, well, 72%, 78% were negative. And then this again remains stable over time. And this looks at the different subsets. And this MRD negativity was seen in all of even the high risk subsets of patients. And we looked in the bone marrow. Now, the bone marrow, the MRD negative rate was not as high. But there are a lot of patients that still need to be assessed. If we look at the different prognostic variables, it turns out that none of these prognostic variables was associated with a worse response to this treatment. So this treatment seemed to do well, even in the various molecular subsets and even in the high IPS. So the patients in all of those subsets I showed you, those at the beginning of the presentation, who had poorer response rates and poorer outcomes, these patients seem to respond just as well to this combination treatment. No patient has progressed yet, which we're very pleased with. These are the side effects. The side effects are um, greater when the patients are getting the combination therapy as opposed to monotherapy. With the monotherapy, there's hardly any serious side effects. With the combination therapy, the most common side effects are neutropenia and febrile neutropenia, and these are not much different than you would expect with BR. There were some dose modifications that were required. But we did do an analysis, and actually, patients who had these dose modifications did do comparably to those who didn't have dose modification. So, just with respect to this trial, these are the highest CR and VGPR rates reported for this disease. And it may be that this, because the toxicity profile is very similar, and because of the exciting data with very high levels of MRD, this could be a superior first line treatment. So we have to wait for the data to mature. We have to wait for this to be peer reviewed. But we are excited about these results, and we're very appreciative of all the people who participated in this trial, both patients and different medical centers. So, in the last few minutes, I'm just going to talk about, well, what do we do when patients relapse from their first line treatment? We expect them to have pretty good responses and durable responses to their first line treatment. Those who have the high risk subgroups may not last as long in in remission, but eventually most patients are going to relapse. How do we treat these? Well, if patients have intolerance to a BTK inhibitor, I mean, the first type of treatment for the most part is a BTK inhibitor. Patients will initially get a BTK inhibitor when they relapse, even though in some situations, if patients have had very long responses to bendamustine that could be considered again. But for the most part, patients will get a BTK inhibitor. Um, they will stay on that BTK inhibitor until they progress. If they have toxicities, doses can be modified, or they can switch to a BTK inhibitor that might be associated with fewer toxicities, and that happens all the time. But what happens when you progress after while you're on a BTK inhibitor? Well, this is where is basically an unmet medical need. We need new treatments. I wouldn't say there is an established treatment yet. There's a number of different options. And a lot of these options are based upon clinical trial results, which are just being brought forward. And the NCCN 2025 recommendations for relapsed refractory Waldenstroms are a BTK inhibitor. Bendamustine Rituxan is occasionally an option, and Rituxan, cyclophosphamide, dexamethasone. But basically, there are a number of different BTKIs that could be used, and you can see that pirtobrutinib, now a non-covalent BTK inhibitor, is also making its an appearance on this list of potential recommendations. But um, these are some of the newer approaches or newer treatments that are now being explored, particularly for patients who relapse after their BTK inhibitor, after their standard of care, let's say zanubrutinib, acalabrutinib, or even ibrutinib. Um, I'm just going to go briefly through some of these results. And the results are not mature. They're not necessarily results that are from manuscripts or large randomized trials. They're results from phase 2 clinical trials. These are the clinical trials that they come from. Some of these have not even reported. Lopofosine is an interesting I-131 radioconjugated against phospholipids that are abundantly expressed in Waldenstrom cells. Nemtabrutinib is like pirtobrutinib, a non-covalent BTK inhibitor. There's a number of BTK degraders, which are in early trials. Loncastuximab is an antibody drug conjugate that targets CD19. Pirtobrutinib, now we see in combination with venetoclax as a possible option. And then there's sonrotoclax, which is a new version of venetoclax, a newer version, which may be a little bit more potent, at least in preclinical models. And I'm excited to see epcoritamab because epcoritamab is a T-cell engaging antibody, bispecific antibody, which is really exciting new drug in many other types of lymphomas. And we're starting to see some data, or we're starting to see this being studied in clinical trials in Waldenstroms. If you look at BTKI pirtobrutinib, the non-covalent BTKI inhibitor, from this study, um, that what you can see is that by Palumba, that there is a pretty good response rate. The major response rate is 88%. It's higher in patients who've never had a BTKI inhibitor, but if you have had prior continuous BTKI inhibitor, it's still close to 80%. And patients will stay in remission. The median is about 2 years. So 50% of patients will stay in remission 22.1 months. Considering this is the third line treatment in most patients, this is a reasonable result. Pirtobrutinib plus has been combined with venetoclax. This is a study by Castillo. And the exciting thing about this is that the results seem to be comparable in patients who are CXCR4 wild type versus mutated, 90% versus 83% response rate. And patients who were previously exposed to a BTK inhibitor responded just as well, 86% versus 89% if you've never been exposed. And the follow-up is short, but the progression-free survival um, is 84% at 6 months. So we're expecting that it will also be fairly long, or uh, before most of these patients start, before 50% of these patients relapse. Venetoclax has also been studied. This PFS is about 30 months in this patient. And again, CXCR4 patients who with that mutation tend to respond just as well as those patients who don't have the CXCR4 mutation. Response rate is 84%. Progression-free survival, as I mentioned, is about 30 months. And there is a relatively higher rate of grade 3/4 neutropenia. Which reaches 45%. But again, that's not really all that surprising in patients with on a third line treatment. Sonrotoclax, this is another newer BCL2 inhibitor or antisense drug. And this is a dose finding study, so it's not as mature as the venetoclax study, but again, response rates closer to 80% at the dose that is thought to be the optimal dose, with a good percentage of CRs and VGPRs. And BTK degrader, this is very short follow-up in this study. It seems to be active in patients with different types of molecular subsets, but the follow-up is very short. The response rate is closer to 93% here, with 25% VGPRs. So I've put all these studies together. Like, so of course the question is going to be which of these would be the optimal third line treatment after one has progressed on a continuous BTK inhibitor. And I don't think there's an answer yet. These drugs, we don't have the final results. We don't have long-term follow-up. We don't have randomized data. They're all pretty comparable. They all have different types of toxicities associated with them. And um, most of these were, as you can see, patients who had failed many previous or been exposed to many different types of treatment, except for the pirtobrutinib and venetoclax trial. And I think we're going to have to wait for further follow-up on these types of trials before we know is there an optimal third line treatment to take after progressing on a BTK inhibitor. All of these are acceptable, but which one is best is very difficult to answer. Um, so I'm going to conclude here. This is my last slide. Waldenstroms macroglobulinemia is an indolent lymphoproliferative disease with an overall favorable prognosis, but there are several unmet medical needs, and there are people with this disease that don't do as well, high risk multiple subsets, multiple relapse disease, um, patients who have a high stage at presentation, and patients who don't have deep responses. And then there are issues with respect to what is the best third line treatment, and what are the how can we reduce the toxicities from continuous BTKI therapy, which is becoming a real concern as we learn more about what these how the frequency of these toxicities. So new clinical trials of novel targeted agents and eventually immunotherapies may help address some of these needs. I'm very enthusiastic about immunotherapies in general. And I didn't show you any results from the BT the bispecific antibody because it's not yet published. Maybe it'll be some data presented in abstract format at ASH. The Canadian BROM trial, which I showed you, shows high activity in high-risk molecular subsets and is a fixed duration regimen that may reduce cumulative toxicities. And multiple novel drugs are in the horizon and have shown activity in relapsed refractory Waldenstroms, but longer follow-up and additional data required to better understand how and when to use these novel drugs. So I'm going to stop now. These the people I'd like to acknowledge and thank, and people who supported our trial. and our co-investigators and families, and the clinical trial support Center for Clinical Trials at Sunnybrook Research Institute um, for sponsoring the BROM trial. And look forward to questions, which will be at a later time, I understand.
Thank you, Dr. Bernstein, for that informative presentation. And as you mentioned, for the audience, I would like to direct everyone to attend the indolent non-Hodgkin's lymphoma Q&A. Thank you and see you there.
Okay.